request Dr. Anand Rajendran. He is the Chief of Vitreoretinal Unit at Arvind Eye Hospital, uh, Chennai. He also has an Zeiss Cirrus 6000, and he'll be talking about diabetic retinopathy.
Yeah. So it's my pleasure to talk to you about OCT angiography in diabetic retinopathy. I'd like to thank Dr. Abrinda for having me here in this IC. So OCT angiography's role in diabetic retinopathy is basically where with OCTA to demonstrate the retinal microvascular changes. So these can be structural or morphological alteration in the form of showing up better microaneurysms, tortuous dilatation, IRMA, NV, collateral shunts, but also demonstrating structural loss in terms of showing up the capillary non-perfusion areas centrally, which is macular ischemia or an enlarged FAZ, or peripherally. And also different indices for looking at structural density, such as perifoveal capillary density, which is fairly popular. So it also shows up different changes in the various stages of diabetic retinopathy. It highlights diabetic macular ischemia, useful in correlating DME with anti-VEGF responses. This is an interesting facet. And also showing up, now that we have wide field OCTA also coming up, peripheral changes of non-perfusion and equating it with the relevant DR stage. Also looking at, very excitingly, evolution or regression of IRMA and NV, and we'll look at all this in a bit. So angiographies, we've talked about this. FEZ corresponds of the fluorescein angiography fairly well with the superficial vascular plexus of the octa. But where octa scores is, this is the only place where you can see deep vascular plexus. So that's important. And OCTA-FAS, now looking at early changes and stages of DR. So early citers of ischemia on OCTA, you can see, if you look very carefully, disruption in the FAZ on the S superficial capillary plexus. In the deep capillary plexus, as and when you find focal microaneurysms, you will find them, interestingly, to correspond more often than not with CNP areas in the choriocapillaries layer below that. Kim et al. Found increased FAZ dysmorphia, diabetic macular ischemia progressing with progression in the stages, as you can see here. And this allows for quantification, and Alam quantified OCTA OCT analysis and helped compute-aided identification and staging of DR. So looking at OCTA-FAS and diabetic macular edema, and as I said, prognosticative anti-VEGF response. So there have been different studies, and the jury is split. Lee and Atala found that increase in diabetic macular edema corresponded well with the FAZ area increase, which Tarasoli and Han did not find in their studies. Looking at an interesting study by Lee et al., where they looked at OCT angiography and its of DME and its association with anti-VEGF treatment response. They looked at 51 poor responders and 32 good responders, and they found, interestingly, this is important, significant damage to the deep capillary plexus, not superficial capillary plexus. And they also said that the marker for poor response would be deep capillary plexus loss and corresponding outer plexiform layer disruption. So this is where OCTA is important, because as I've just said, OCTA is the only one which shows up pathology of deep capillary plexus, not your FA. So you see here a good responder, an example with lesser distortion of the deep capillary plexus and more microaneurysm being shown on DCP than the fluorescein angiography. Similarly, in a poor responder, there was greater distortion of DCP and again more microaneurysms on DCP than FFA. Now we, after we looked back at a few of our cases, and we looked at cases with good response to anti-VEGF injections. You can see from baseline to 3 months post-injection, fairly good regression. And we found that there wasn't too much of a difference in the superficial capillary plexus. But yes, in the deep capillary plexus, there was definite dysmorphia, and you found that it improved fairly well with treatment in the good responders. Now we look at a case of a poor responder where there was hardly any improvement. In fact, there was worsening. So you see that in the superficial capillary plexus, not too much of a change, but in the deep capillary plexus, you find significant increase in the dysmorphia. And 1 month post-injection, you can actually find that as it's becoming worse on the DME, the DCP FAZ is also increasing. Now looking at OCTA-FAS and diabetic macular ischemia, Rosen et al. Showed this in this index which I was talking about, perfused capillary density. So in controls, you can see the red area on the far right panel, which is the capillary density map. That increases in no in diabetics without diabetic retinopathy. So perhaps in this little twilight zone, there is an increased metabolic push to increase the vascularity because the retina sensing changes. But as it moves from into organic pathology, from no DR to NPDR to PDR, that perfused capillary density is now dropping off slowly. So you can see that red is going and becoming yellow. So Bradley et al. From the Moorfields group, they looked at 24 patients with diabetic macular ischemia, and they evaluated this using OCTA, and they clinically defined it as an enlargement of the foveal avascular zone and paramacular areas of non-perfusion. And they compared FFA versus OCTA, the three SCP, DCP, and choriocapillaris. They brought out a novel DMI grading system and looked at it for reliability and consistency. And this is how they graded it. The FFA and the SCP, as I mentioned, these two correlate. They had different grades: absent, questionable, mild, moderate, severe, ungradable. So mild, moderate, severe was based on the FAZ outline description, and mild, moderate, severe is less than or more than half disruption of the original circumference or complete in severe. The DCP, they split it into a 4-quadrant grid. They did the same for the choriocapillaris also. And again, there is absent, questionable, mild, moderate, or severe, ungradable. So mild moderate was FAZ disruption with less than equal to 2 quadrants, and severe was when it was more than 2 quadrants. And it was just a plus or minus response with the choriocapillaris, loss of speckled hyperreflectivity, homogeneity, dark defects if it is present. Then you said macular ischemia was there at the choroidal level. So this is just an example to show what they mean. So this is FFA, which showed diabetic macular ischemia less than half of the FAZ. OCTA SCP correspondingly had the same DMI less than half FAZ. So based on these two, there was mild moderate ischemia in the superficial layers. The DCP showed fast disruption. In the subsequent slide, I'll show you how they graded it. OCTA capillary there were dark defects, so they concluded there was ischemia at the choroidal level. So in the DCP, you find there's 2-quadrant FAZ disruption, and according to their classification, this qualifies for mild to moderate DMI at the DCP level. And you see choriocapillary is also the 4-quadrant, so the DMI is positive because choriocapillary dark defects are positive. So the key findings was the degree of diabetic macular ischemia can be reliably assessed by OCTA, SCP, and more objectively than FFA. And there was moderate agreement between DMI gradient results for OCTA of SCP and FFA. And OCTA DMI assessment, there was much better substantial intergrader agreement than it was with FFA. So the different readers, there was greater agreement between them for OCTA. And OCTA DMI grades correlated very well with the OCTA parafoveal indices also. Now, comparing DMI with peripheral capillary non-perfusion. This is a question which often comes up in conferences. So here, Handel et al. Showed that OCTA phase dysmorphia and diabetic macular ischemia correlated very well with increasing peripheral capillary non-perfusion. Now, looking at wide field OCTA and what implications it has, especially for PDR. So one of the advantages of wide field OCTA is combines both structure and flow information, identifies extent of retinal non-perfusion, detects onset and severity of macular edema, intraretinal microvascular abnormalities or IRMAs, as well as retinal neovascularization. It's useful to determine when to treat and for following response to treatment, and it lends itself very well for futuristic novel staging criteria for diabetic retinopathy. It's an example of a 41-year-old male who has diabetic macular retinal thinning, as you can see here, and this corresponds fairly well to an area of capillary non-perfusion on the 3x3. When you move on to a 6x6, you see that it corresponds well to the retinal thinning out there on the RPE. And when you move to 12x12, you see that it also correlates to different multiple areas of CNP in the periphery. Now, another patient with DM, you see on that small little macular thickness map here, this extent of the macular edema. And of course, you see there's a lot of macular edema there. Now, with the wide field, when you look at a 15-15 retinal thickness map montage, you see that area is actually much larger than what your original capture was. So this corresponds to the macular edema and this peripheral capillary non-perfusion in the distance. And when we move that slab up, so the previous one was a superficial slab, and I think I skipped pages. Yeah, right. So now in this patient, this is a 15-15 retinal thickness montage, and you see that thickness out there, and this corresponds with non-perfusion out there. And when you move to that VRI interface, so in this superficial flow montage, you see the line, the slab is right here. So this is superficial. You're getting all the superficial capillaries. You're seeing the non-perfusion area. That's fine. But when you bump that slab up to the VR interface, vitreoretinal interface, which is here, you see in isolation that elevated neovascular tuft. And this is beautiful in picking up early neovascularization. You see one there, and this corresponds beautifully on the VR interface to this bump which is rising up. Similarly, on the right side, you find another area of neovascularization, and that corresponds to a small bump there. So this moving of the slab, which I think Dr. Abnindra also referred to, is so critical in picking up pathology. And this is another gentleman with multiple areas of macular edema, as the flow map shows. And also there's a non-perfusion. And you see here a very small area right up there of neovascularization, which you missed completely in the previous flow map, which was superficial retina. So moving it to the vitreoretinal interface really helps in picking up these early tufts of neovascularization in PDR. So yeah, just went past. So high magnification SSOCTA helps look at IRMA evolving into neovascularization. So in baseline, you see here, there's some flow density increase at baseline, and that is slowly increasing. At 1 month, you see it's just reaching up to the surface, and at 3 months, you see it's breaking through and forming that neovascularization. It's also great for looking at evolution of NV, as I mentioned earlier. It's captured on Octa. You see a little bit of neovascular tuft there. On the flow map, you see there's a little hyper vascularity there. In magnification, you see it's still below the ILM. So it's still IRMA. And in time, in 1 week, you see it slowly coming up and pushing up that ILM, and you're seeing the early birth of a neovascular complex. Now, after 1 month, you see it pushing up further, coming up above that level, and at 3 months, you see it bursting through, and now it's a full-blown NVE. So this is great documentation of IRMA going on to becoming a NVE. And so Russell et al. Showed that IRMAs can directly evolve into neovascularization. This evidence was first given by swept source Octa, and it mandates early detection, helps early detection and frequent monitoring of the IRMAs, as well as early detection of neovascularization and diagnosis of PDR. So using the same field of view, wide field SS Octa gives you as much as ultra wide field fluorescein angiography. All IRMAs, NV, and areas of retinal non-perfusion identified. Changes on ultra wide field fluorescein angiography also seen with wide field SS Octa. Wide field SS Octa is all that's needed to diagnose and manage every stage of diabetic retinopathy. So DR stages increased in conclusion, increased fast dysmorphia, DMI correlates with progression in stages of diabetic retinopathy. The grades, increased DME severity, phase area, foveal thickness corresponds to worsening of visual acuity, so functional correlation there. DME and anti-VEGF response, poor responders, remember the significant damage to DCP, not really superficial capillary plexus. It's a marker for poor response, deep capillary plexus loss, and corresponding OPL disruption. Diabetic macular ischemia, degree of diabetic macular ischemia can reliably be assessed by Octa SCP changes. In Octa DMI assessment, there is substantial intergrader agreement, which is better than what you will get with FFA. Peripheral capillary non-perfusions, octa-phase dysmorphopsia, and DMI correspond to increasing peripheral capillary non-perfusion. And while field SS OCT imaging has the potential to replace color fundus imaging and FFA as the gold standard for routine assessment. As I say, routine assessment, routine non-invasive assessment of disease severity, staging, and deciding when to treat. Future perspectives may be the doctor may be promising non-invasive tool in daily DR screening, and the advent of AI and machine learning coupled with DR Octa big data may herald a new age of preclinical diabetic retinopathy screening, clinical DR staging prognostication based on Octa markers. Thank you.